Jayawardenapura Hospital. It's regarding atrial fibrillation.
Good afternoon, ladies and gentlemen. Right at the onset, I'd like to thank the President of the Sri Lanka College of Cardiology and the President and the Organizing Committee of the Kandy Society of Medicine for the very kind invitation. It's indeed a pleasure and a privilege. It's always good to be back in Kandy. A slight changing pace. We fast forward, and it is about rhythm, atrial fibrillation. What is AF? It is easily the commonest cardiac arrhythmia, and it is defined by indicated by irregular rhythm with no discernible P waves. Little bit of pathology and physiology. What do we need for atrial fibrillation? You need only two things: a trigger and a way to sustain. The triggers are usually from the pulmonary veins, usually, but there can be atrial ectopics which come from the either atria or by around the coronary sinus even. But commonest culprits are the pulmonary vein, the four pulmonary veins. And the how to sustain is by way of a slightly diseased atria, either anatomically diseased atria due to a little bit of fibrosis, or electrically diseased atria because due to ion channel abnormalities which can occur with the advancing age of various syndromes or genetic propensity that we don't really know yet. Or the other thing is, people, the ones who are working in ICUs, we know that every other patient goes into atrial fibrillation one time or the other as a result of internal environment going haywire due to metabolic derangements. So, and so what triggers it is like lighting a match. One atrial ectopic of you can trigger atrial. It's like setting fire to some wood, dry wood, and which sets off a campfire, which ends up being a forest fire, because the atria will start firing about 500 times a minute. It doesn't really contract, but it will start about 500 times a minute during atrial fibrillation. It's a well-known fact. It has people have been living longer, aging, and AF increases, obviously, the incidence and the prevalence. So is the information about atrial fibrillation. 2010, if you do a Google search, it will reveal about 2 million hits. Just the other day, I searched nearly 29 million hits. So much information about atrial fibrillation on Google. So it comes down to how to manage. The age-old question, rate or the rhythm? It's not that simple anymore. Stroke prevention, obviously, so that is the biggest problem in AF. Symptom relief, as the president said, it has to be patient-centered. Symptom relief, very important. Why patient comes to us is because of the symptoms, not because of anything else. This is a very old study back in 2002, a firm trial, and which compared rate control versus rhythm control, and this is old information which didn't really show much difference between the rate and the rhythm control when it comes to overall outcome, disabling stroke, bleeds, cardiac arrest, mortality. And in fact, actually, they demonstrated that people with rate control lived slightly longer. This is as a result of the problem with antiarrhythmic drugs. Fast forward to 2020 October, they decided to revisit, because as a result of a lot of information that was gathering and also the experience of the physicians, they decided to put a whole lot of brains together, and this was published with regard to rhythm control, and that led to this, which was just published in American Journal of American College of Cardiology, East AF Net 4 trial, which was published just exactly a month ago. And the results showed us it is not that simple. The answer, it is not a yes or no answer, because the results showed that the early use of rhythm control to reduce AF, we call it the AF burden, and to related adverse clinical outcomes when it applied early. Okay, thing is early. You hit it hard. You hit it early when it comes to atrial fibrillation. And the thing with this trial, which just like a firm trial used about more than 4,000 patients, they realized, because they actually, just like Dr. Pathirana said, very meticulous management as much as possible, hypertension with ACE inhibitors, ARBs, like Dr. Mubarak said, the statins, and oral anticoagulation, better monitoring with oral anticoagulation, and also using some of the novel anticoagulants which are still limited access to us, with those along with that they went for rhythm control. And also when they gave rhythm control drugs like toxic drugs like amiodarone, they managed them, they followed them up fairly closely, and then they realized the overall outcome was better with rhythm control, and provided that it is started early. When you say early, that is within 1 year of detecting atrial fibrillation. So and so, treat comorbidities, better oral anticoagulation. So obviously, and early initiation of rhythm control, there was a clear advantage. So then there was a practice was plus evidence put together. Rhythm control is preferred therapy now it is agreed by the European and the Americans. For once, they have agreed. First step is soda wave. Go for rhythm control. Be aggressive. And we all know atrial AF less than 48 hours. We will not be just procrastinating. We will be starting them on low molecular heparin, oral anticoagulation, cardioversion, either mechanically or electrically, or with amiodarone. It's available to us, and keep them in sinus rhythm. And if there's a reversible cause in the setting of acute coronary, the patient gets myocardial infarction, they go into atrial fibrillation. You do PCI, you give tenecteplase, but you aggressively manage the atrial fibrillation also, not just get settle for rate control. Symptomatic patient, despite of rate control, which we see quite a bit. Heart failure, patient going into heart failure with the atrial fibrillation. Sometimes it doesn't have to be that fast also, the ventricular rate, for them to go into heart failure, because they have low cardiovascular reserve. Young AF patient, we don't want to keep them in atrial fibrillation, because atrial fibrillation begets atrial fibrillation. So longer you leave someone in AF, more anatomical and electrical changes occur in atria, which gives rise to more atrial fibrillation. A paroxysmal patient, you don't manage it all that well, they go into persistent AF. After 5 or 6 years later, they become permanent AF. Then, of course, no point in even talking about rhythm control. So, rhythm control options which are available to us: amiodarone, the age-old drug. Unfortunately, we don't have dronedarone yet. Dronedarone doesn't have the side effects of amiodarone, but it is actually efficacy-wise, it is less. We have sotalol, and now flecainide has become available to us, provided there is no structural heart disease or no coronary artery disease. So, and you must not combine amiodarone and sotalol due to QT prolongation. And particularly, if you are giving sotalol, we have to monitor the QT interval. Amiodarone, invariably, you will get some QT prolongation, but it is not proarrhythmic as such. But sotalol can be. Flecainide, when you are giving, look for a widening of the QRS complexes. If the QRS complex is widening, of course, that will be a time for us to take the flecainide away. A little bit about atrial fibrillation ablation also. And when should we settle for rate control? That is, it is preferred if the persistent or permanent AF, which is in our setup. You can get actually patients with eternally with severe mitral regurgitation, mitral stenosis, large LA, severely impaired LV function. See ejection fraction 30, 35. So very difficult for them to maintain sinus rhythm, because LV function is a very important factor when it comes to keeping them in sinus rhythm. If you have two or more antiarrhythmic drugs have failed, we might have to settle for uh, rate control. So what are the rate control options? Just always number one would be the beta blocker. So much of benefits and mortality benefits. I cannot emphasize it enough. Bisoprolol and metoprolol are superior because they have better action on the AV node. Better action on the AV node. Carvedilol and atenolol has the least action on the AV node. So if they are contraindicated or if they are not working, we can actually non-dihydropiridine calcium channel blocker, verapamil or diltiazem, which also have a AV nodal action. And when combining, we have to make sure that we don't cause complete heart block, but it can be combined. Digoxin, the age-old drug, almost got forgotten, but it is making a comeback. Rate AF trial, which was just published in August 2020, and which has showed a marked benefit in patients with particularly with difficult to manage permanent atrial fibrillation. They are obviously an older age group. The concern with digoxin earlier with regard to arrhythmogenicity was because serum potassium was not all that well managed, because digoxin side effects occur in the hypokalemia, and also digoxin itself actually brings down the potassium. So potassium levels uh, to be uh, to be monitored, and combined with ACE inhibitors or ARBs, actually they do quite well. Permanent atrial fibrillation, and also combining that with beta blocker also can be done, provided you monitor them well. And rate control option, amiodarone as a rate control drug, only it is a third line drug. It is I see them people starting amiodarone just like giving candy to kids on the Halloween. One should never do that, because amiodarone you have to use it judiciously. But in patients with atrial fibrillation, critically ill, difficult rate control, going into heart failure, actually you might have, if the blood pressure permitting, might have to can use it in the ICU setting IV. And then atrioventricular AV blockade and implantation of CRT or or a pacemaker is actually, when everything else has failed, it is actually palliative measure. And then we come to stroke prevention. And we all know Chad Vasco, I'm not going to go on about it as we are a little short of time. Important thing with the patient has heart failure, hypertension, age more than 75, of course, 2, diabetes, stroke, other vascular disease, age 65 to 74, we give 1. Ladies get 1 point, 1 more point. So two or more of these, of course, oral anticoagulation. Then we all know about this drug. We are hitting the benefits, balancing the benefits versus the risks. Important sweet spot, as our president said, it's between 2 INR, between 2 and 3, to prevent stroke and to minimize the bleeding. And another problem that we see, everyone likes to, not all, but a lot of the time, people like to start them on antiplatelet drugs, thinking that they are safer. Not really. Actually, the bleeding obviously is with even with oral anticoagulation is more above the age of 80, and above the age of 80 or more, bleeding risk is significantly more. But however, how do we minimize the bleeding with oral anticoagulation? As much as possible, close monitoring of INR to keep it within the therapeutic range, and meticulous control of blood pressure. As even the slightest reduction of blood pressure actually markedly reduces the chance of them getting a CNS bleed. Um, and also when it comes to warfarin, combining with antiplatelet drugs, actually as much as possible combine it with single antiplatelet rather than with a dual antiplatelet therapy along with warfarin. So warfarin, we all know about it: effective, reversible, tested, inexpensive. Drawbacks: slow onset of action. Takes about 72 hours to start action. We might have to give about something like low molecular heparin to keep to prevent thromboembolism. It needs regular monitoring. Quite cumbersome. Outstation, and if they don't like drugs being drawn all the time. Food and drug interaction, whole lot. We have to remember. Patients have to remember. And we all know about the in clinical practice how difficult it is to maintain the INR between 2 and 3. Here comes the novel anticoagulants. Rivaroxaban, it is an activated factor 10A inhibitor, and it is you can give it once daily, 20 milligrams a day. Actually, it is been slightly proven to be slightly better than warfarin, less bleeds overall, and there's no need for routine lab testing. Apixaban also is available. Either we can give 5 milligram BD if the patient is above the age of 80 or high serum creatinine, we can give 2.5. They are also as effective, less bleeding. But the problem is that with novel anticoagulants, they cost about 12,000 to 18,000 rupees a month. At the moment, because of the limited registration, because it is available only with a few distributors we still prescribe, and there is a problem with registration in life-saving drugs. There is absolutely no problem in registering useless multivitamins and supplements in this country. God help us. And then dabigatran, the direct thrombin inhibitor, which is also available. Difficult to get to, but it is irreversible. So, who should remain on warfarin? Patients already who are on warfarin and doing well. Why try to fix it if it is not broken? And the limited access. Most of the time, patients find it difficult to get it because it's just not available everywhere. Cost, obviously, and some patients, things like apixaban, patients might not like twice a day. And CKD, the EGFR is less than 30. 30, of course, still warfarin will be the drug. Obviously, as Dr. Jayawardenapura said, the mechanical heart valves, still worldwide, warfarin would be the drug. So, as I said earlier, clopidogrel aspirin, there is no significant reduction in the stroke because these patients, either CAT-SWAS score is 2 or more oral anticoagulation. So half measure we give aspirin, clopidogrel. It is for our own some sort of reassurance, but it doesn't actually do patient any good. But it does give rise to significant increase in the bleeding aspect, because the first line of defense, in particular in elderly, of bleeding is the platelets, not so much the clotting factors. So platelets, antiplatelets will cause more bleeding. So catheter ablation, a few words about catheter ablation. We can, it's still very limited in Sri Lanka because we lack 3D mapping facility. We need the 3D mapping facility, and it is we are in the process of trying to establish one at Jayawardenapura. And one is that it will be done from the right femoral vein, and we go into right atrium, the transseptal puncture to the left side, and by drawing lines around the pulmonary veins, we isolate the pulmonary veins. So ablation is certainly not for everyone. If the antiarrhythmic drug therapy has been proven to be ineffective, if they are not tolerated, or symptomatic AF despite medical management, and the fourth category is younger patients. Younger patients who get repeated episodes of paroxysmal atrial fibrillation, who do not want to be on medical management for long periods of time, they do quite well if you do the pulmonary vein isolation. But that is not a big population in our country, unlike in UK, which we saw a lot. younger patient may have something to do with genetics and also their body habitat. Some our young patients tend to be a little thinner. Obesity is obviously a big risk factor for atrial fibrillation. So the ablation might benefit in patients who refuses antiarrhythmic drugs, and also some patients who have some AV nodal disease also, who, because when we give drugs, they go into severe bradycardia. So those patients also might benefit from an atrial fibrillation ablation. Altogether, the patients with persistent atrial fibrillation don't do well at all with ablation. So that is out. Paroxysmal AF, younger patient, minimum structural heart disease. Of course, these patients with large LAs and all, you can't do ablation. And the success rate at the best centers for paroxysmal AF event, success rate is about 60%. When success rate is defined by sinus rhythm maintenance at 5 years. So that is only 60%. So there are limitations with ablations also. So as I said, no ablation has not been proven to reduce stroke risk. So they have to be on warfarin. So patients, our patients in particular, it is going to be a bit of a drawback. Ultimate goal is to get somehow rhythm control as much as possible without antiarrhythmic in at the moment with antiarrhythmics. This is consultant cardiologist Dr. Vasanthi Ratnayaka, consultant physician Dr. Priyamali Jayasekar, consultant endocrinologist Dr. Niranjala Meghadvitan, and of course yours truly. 13 years ago, was studying for MD Part 2 at the room that we just had tea. Thank you very much for your attention. I managed to finish.
Thank you very much, sir. I would like to invite Dr. Kularatna, consultant cardiologist from Kandy, to hand over the certificate. Thank you very much. Moving on to the next lecture, it's regarding new therapies in heart failure by Dr. Sanjeeva Rajabaksa, consultant cardiologist from Ragama. So,
Hey, good afternoon, everyone. Would like to thank President Lanka College of Cardiology and President of Kandy Clinical Society for giving me this opportunity to talk to you on a very important subject, which is being more commonly found in the world, becoming more prevalent, and we are running a 1 in 5 risk of developing heart failure in our life.